All right, so what we're going to do is we're going to break the talk up into three parts. First of all, we're going to talk about the problem of obesity, and then we're going to talk about the treatment options for that problem, and then what to expect before and after surgery. And just to emphasize a few key points, surgery is only part of the program. So by itself, it really doesn't make much sense. It only makes sense in the context of a total lifestyle change and lifelong follow-up. Complications are certainly possible from the surgery, but the benefit of surgery far outweighs the risk. And the key to success is follow-up. This is unlike any other operation that we do. The follow-up for this procedure is lifelong. So, what is obesity? It wasn't until year before last, I believe, that the AMA formally recognized obesity as a disease. And that's an important distinction because once you understand obesity as a disease, then you can start thinking about treatment options. We know that this disease is multifactorial, and that it's not just one factor that causes it. We know that there's a big genetic component to it. We know there's a behavioral component, and we know that there's an environmental component to it. We care about it because it's potentially life-threatening. In order to talk about obesity scientifically, we need a medical scientific definition for it. So we do that in terms of body mass index. Has everyone calculated your BMI already? All right, so BMI, if you haven't done it already, it's a calculation based on your height and your weight. And we use that because if you're 6'10" and you're 200 pounds, you're probably underweight. If you're 200 pounds and you're 4'10", you're probably overweight. So BMI kind of equalizes that based on your height. A normal BMI is between 18 and 25. Overweight is considered a BMI over 25. Obese is a BMI over 30. Severely obese is a BMI over 35, and morbidly obese is over 40. And it's traditionally those last two categories that we start thinking about as surgical treatment for obesity. So if you haven't calculated your BMI already, here's a little chart. So just as an example, if you're 5'4" and you weigh 205 pounds, that would be a BMI of 35. If you're 5'4" and you're 230 pounds, that would be a BMI of 40. And the easiest way to calculate your BMI, if you haven't done it already, is just Google BMI calculator, and a million of them will come up, and you just type in your height and your weight. Now, ultimately, we really don't care about how heavy we are. What we care about is how healthy we are. So we're concerned about the comorbidities or the other illnesses that go along with being obese. And of course, there's the medical ones that we always think about, like diabetes and high blood pressure and that kind of thing. But there's also social, economic, psychological, and physical issues that go along with it. Socially, certainly people form an impression about you based on the way you look that isn't necessarily accurate. The reason Chris Christie is up here is because this was now about 8 years ago. During the last presidential election, he was being considered as a candidate. One of my colleagues, another doctor in the doctor's lunchroom, said, "I would never vote for Chris Christie for president." And I asked him why. He said, "Well, if he can't take care of himself, how can he take care of our country?" And obviously, the person who said this wasn't governor of anything. Chris Christie was governor of New Jersey. And whether or not you agree with his politics, he's certainly a very intelligent and accomplished person. But yet, this other person had made a judgment about him based solely on his appearance. It just goes to show you how far we still have to go in terms of understanding the disease of obesity, even among medical professionals. Now, psychologically, if you're overweight, you're 5 times more likely to be depressed than a normal weight individual. And of course, this can put a strain on your personal relationships, and if your coping mechanism for your depression is eating, that can get into a vicious cycle. Medically, there are over 60 different illnesses that are associated with being overweight. It's not just the normal ones we think about. Certainly, you have things like pulmonary disease, abnormal pulmonary function test, sleep apnea, like we mentioned before. You can have liver disease. Has anyone heard of fatty infiltration of the liver or fatty liver? So that can become so severe that you get cirrhosis, and in fact, that's about to become the leading cause of liver transplantation in the United States. You can get gynecologic or urologic issues like abnormal menses, polycystic ovary syndrome, infertility, stress incontinence, and then also things like cardiovascular disease, dyslipidemia would be high cholesterol and lipids and that kind of thing, hypertension, diabetes, and then cancer. Not many people realize that being overweight is associated with cancer. We'll see a little bit more about that in a minute. So just to hit a few of the specifics, with diabetes, if you are overweight, that increases your risk of diabetes by 400%. In fact, 90% of all type 2 diabetes is associated with being overweight. That's led the International Diabetes Foundation to issue this position paper, which was a real shift in the way that we think about diabetes. Because traditionally, what type of doctor treats diabetes? Does anyone know? Well, it's going to be a medical doctor, like an internist or an endocrinologist or a family practice doctor. This is saying that we need to start thinking about diabetes as a surgical disease, because we know that 90% of all type 2 diabetes is associated with being overweight, and we've got a procedure that fixes that. So the other thing it says is we need to start treating diabetes early before people get the complications like blindness and amputations and those sorts of things. Now, in terms of hypertension, 75% of all hypertension is due to being overweight. With lipids like cholesterol, it gets you both ways, because obesity increases your bad LDL cholesterol and it decreases your good HDL cholesterol. We know that obesity is very strongly associated with sleep apnea, and by the time your BMI is, by the time you're in the category of morbid obesity, up to 50% of people have sleep apnea, and it's tremendously underdiagnosed. So a lot of people go around tired all day and they're not sure why, and the reason is because they stop breathing at night and they're not really getting good sleep. And then all of this kind of plays into metabolic syndrome. Metabolic syndrome is something that we really just started to recently think about. Back in the 80s and 90s, we noticed that people who have high blood pressure also seem to have diabetes. They also seem to have heart disease, and they're also overweight. But we treated all those as separate illnesses. We understand now that those are symptoms of a larger disease called metabolic syndrome. And the cause of metabolic syndrome is obesity. So by treating the obesity, we can cure all these symptoms of metabolic syndrome. And then, of course, cancer. So notice that all these different types of cancers are associated with being overweight. So uterine cancer, breast cancer, colon cancer, they don't seem to have anything to do with each other. So what's the common thread? The answer is that obesity is perceived by your body as an inflammatory condition. So as far as your body's concerned, it's always injured, or it's always has an infection, and that drives your cells year after year until they make a mistake. And when they do make a mistake, that mistake is cancer. So to the point that they think 20% of cancer deaths in older women and 14% of older men are due to being overweight. All right, so all this affects your longevity. If your BMI is 40 or above, your chance of dying compared to a normal weight individual is almost 400% greater. So it has a big, big impact on your quality of life and how long you're going to live. Unfortunately, this problem has been getting worse and worse as the decades go by. So if you look at our own state here, Louisiana, in 1990, about 10 to 14% of us were overweight. By the time we got to 1999, it was about 20 to 24%. By 2008, it was over 30%. And by 2012 or 2013, we were the #1 most obese state in the nation at about 37%. Now, it's affecting children also. So since the 1980s, the rate of childhood obesity has doubled, and the rate of adolescent obesity has tripled. And as we know, if you're overweight as an adolescent or a child, you're probably going to be overweight as an adult. And then here's a little fact for our own state. At this time, we were #1 out of the entire country for obesity and 3rd for diabetes. We've since fallen to #3 for obesity in the past couple of years. We didn't get any lighter, but 2 other states got heavier. So that worked out well for us. All right, so obesity is a bad problem. It's becoming more and more prevalent, but the question is, why are we obese and why are we getting more obese over time? Well, the human body is designed to operate under a pretty specific set of circumstances. So we're designed to have to work fairly hard for the food that we get, and then our bodies are not expecting that food to be very rich in calories, and especially not very rich in simple carbohydrates. And that's the exact opposite situation that we have right now. We never have to walk very far to get food. We're always near a food court or a vending machine or something like that. And that food that we get is going to be very, very high in calories and simple carbohydrates. So here's an example. This is a bloomin' onion from Outback. And I don't know if you can see the calories for this is about 1959. Now, keep in mind two things. One, 2,000 calories is about what an average adult male needs for the entire day for calories. Also, this is an appetizer. So this is what you eat to get ready to eat one of your 3 meals for the day. Portion sizes have been getting bigger. If you look at this over here all the way to the right, this is a adult size McDonald's soft drink in 1955. So 7 ounces. Now the present day children's size is 12 ounces. And of course it goes all the way up to the teen gulp at 7-Eleven, which is 128 ounces. And soft drinks are pretty much just pure high fructose corn syrup. We don't get as much sleep as we used to. We're all kind of chronically sleep deprived. We know now that promotes weight gain. And of course, we don't exercise as much as we used to. So what our doctors have told us is that weight loss is easy. All you have to do is to take in less calories than you expend. So you need to just push away from the table, right? And you need to get up and move and start exercising. If you do that, you'll lose weight. Now, strictly speaking, that's true. If you take in less calories than you expend, you will lose weight, right? Because that's just physics. Those are the laws of thermodynamics. However, as a way of thinking about weight loss, it's almost completely useless. And here's why. It implies that we are able to consciously regulate the amount of calories we take in and the amount of calories we use to an extraordinary degree of precision. If we are to maintain our weight to within 1 pound a year, that means we need to match our caloric intake and expenditure within 11 calories per day. So that's about half a saltine cracker. If we are off by 30 calories a day, we will gain 200 pounds over our lifetime. Now, the simple fact that most of us don't do that tells us that there is something else going on here. And that something else is the brain. So there is an unconscious regulatory system at play here that regulates how hungry we are, what type of foods we crave, and how much energy we expend in terms of our metabolism. So in the same way that we don't decide how many times to breathe a minute or how many times we're going to blink, we don't really decide how we're going to regulate this system. They've done studies on mice and rats, and animal studies are good because it takes out all these other factors. There's no willpower issues or environment issues or anything like that. They're just animals in a cage, and we can feed them whatever we want and they'll eat it. Here's what we figured out. There seems to be a set point for weight. So this black line is what rats and mice will weigh as they get older. So just if they eat whatever they want. So just like us, they tend to get a little bit a little bit heavier as they get older. If you overfeed them, so force feed them, they will predictably gain weight. But as soon as you stop doing that and let them eat whatever they want, they'll go right back to that same weight. If you underfeed them, they will lose weight. But then you let them eat whatever they want, they go right back to this weight. So what's going on here is there's a set point for weight that's like a thermostat. So as soon as you let them eat, their bodies will automatically get them back to that number that their brain thinks they should be. These are all the little hormones that are in charge of that. Ghrelin, peptide YY, CCK, amylin. These are at work in us, and we find that if people try to diet, their body will take steps to bring them back up to that weight. So it'll increase their hunger drive, it'll change what types of foods they crave, and it will decrease their metabolism in order to maintain that weight. Because your body's perceiving weight loss as a bad thing. It thinks that the crops have failed or the caribou migrated or something like that, and now you're starving. So it'll try to preserve your weight. Well, that kind of leads to the question, then what determines the set point? What sets that number? A big part of it is genetics. We know that about 40 to 70% of our weight is determined solely by genetics. So there's nothing much we can do about that. There is, however, something called epigenetics. Epigenetics are changes to the way that your genetic code is expressed. So your genetic code stays the same, but the genes that are expressed are different based on your behavior. And the interesting thing about this is that can be passed on to your children. So if your parents had bad habits, they didn't exercise, they didn't eat right, It changed the way their genes were expressed, and they passed it on to you. The good news is it can go the other way also, and they actually did a study with fathers who exercised before they had children, and they found that the way their genes were expressed, the way that changed based on their exercise, was passed on to their children. So it can work in reverse also. Now, diet composition has a big effect on that number in that set point. We know now, well, let's put it this way. When we talk to our patients about weight loss in the past, we simply said you need to eat less calories. What counts is the total number of calories you take in. But what that implied was that all calories are equal. In other words, if you take 100 calories of sugar and 100 calories of chicken breast, that our body will treat those the same way. Now, we know that that's not true now. When you eat simple carbohydrates, like sugar or bread or a potato, you get a huge insulin spike. And the job of that insulin spike is to get that sugar out of your blood so that it maintains a normal blood sugar. The way it does that is it converts it to fat and stores it. But now notice, it's gotten it out of your blood, but you haven't used it for energy, so you still need energy. So the next thing that happens is you get hungry. So you take what you eat and store it as fat, and then you get hungry, and then you need to eat more. Protein does something different. Protein makes you less hungry, and it helps to build lean muscle mass. Now, muscle is a very expensive organ. And by that I mean, even when you're just sitting around on the couch, if you've got muscle mass, that's burning a lot of calories. So it makes you less hungry, and it increases your metabolism. And so in that way, we can change that number for our set point. They found also that the type of bacteria that live in your intestines is important and plays a role in whether or not you're heavy. If you take bacteria from a heavy person and you put it into a lean person, that lean person will gain weight. It works in reverse too. If you take the bacteria from a lean person and put it into a heavy person, that person will lose weight. And they're just now trying to figure out why that is, but they think that those bacteria in the colon make certain chemicals that interact with receptors in your intestine and signal to your brain and cause that number for your set point to change. So the purpose of talking about all this is to say that our historical view of obesity is wrong. Whereas in the past we thought that this was some kind of choice people made, or it was a willpower issue or a character flaw. We know that this is now a very, very complex physiology that relates to a regulatory system that is not functioning properly. So once we understand it that way, we can talk about what we can do to fix that regulatory system. All right, so what are our weight loss options? Well, the first 10 things everyone should try is diet, exercise, and behavior modification. Some people will succeed with that, but if you study it in a large group of people and look at it objectively the same way you look at, say, an antibiotic or a chemotherapy drug, it turns out that it's not that effective. On average, people will lose about 10% of their excess weight doing this. So if you're 100 pounds overweight, that means you lose about 10 pounds. Now, that's still good, and you can get a lot of health benefits from even losing 10 pounds. The problem is only about 5% of those people will be able to keep that weight off for any significant length of time, meaning months or years. What about weight loss drugs? Those are effective. You can expect to lose about 10% of your excess weight with those also. The problem with that is most of them are not designed to be used long term, and a lot of them are bad for you. They're basically modified forms of speed. They're types of amphetamines. So while you can get some benefit from them, as soon as you stop them, the rate of weight regain is almost 100%. Weight loss surgery, on average, if you take all the different types of surgeries that we do and all the different patients that we operate on, you can expect to lose about 55% of your excess weight and keep it off forever. So the two things to notice about that number are, one, it's far and away the most effective treatment for obesity that we have. But two, it's not perfect, because on average these people are still 45% overweight. But they're much healthier. Hopefully they've gotten off of their medicines, they're diabetic, they no longer have high blood pressure, and they're going to lead a longer, healthier life. So who then qualifies for weight loss surgery? Well, in the early 1990s, the National Institute of Health issued a statement that said, we think that if you have a BMI over 40, you should qualify for weight loss surgery. That roughly corresponds to being about 100 pounds overweight. Or if you have a BMI over 35 and at least one illness associated with being overweight, we feel like you would qualify as well. Now, they were pretty much just guessing. They had to come up with something so that there was a guideline for who to apply the surgery towards, but they kind of just guessed. Now, they guessed pretty well, it turns out, because all the studies they've done since that time have shown a great benefit for people in these categories, but they've also shown that people with what we call class 1 obesity, which would be a BMI over 35 and at least one illness, benefit greatly as well. Now, most insurances aren't paying for that yet. Some do in California and New York, but most don't yet. So in addition to those BMI criteria, you should also have had a failure of dietary and lifestyle modifications. In other words, this shouldn't be the first thing you try to lose weight. No uncontrolled drug or psychiatric problems, just so that you can focus all of your attention on succeeding with the surgery. You should demonstrate a clear understanding of the risks and complications associated with surgery, and that's what we're going to do here today. And then most importantly, again, a commitment to lifelong dietary, exercise, and follow-up regimens. So unlike any other surgery we do, let's say we do a gallbladder surgery for you. We would see you once afterwards, we'd check your incisions, make sure your symptoms went away, and then say, great, call me if you need me, and that's it. With this, we see each other basically for the rest of our lives. So the typical story that we hear is, I know someone who had it about 5 years ago, they've gained most of their weight back, and when you ask when's the last time they saw their surgeon, it's usually 5 years ago. So they've done scientific studies on this actually. The simple act of coming back and following up makes you lose weight. And there's a bunch of reasons behind that, but just doing that helps you to lose weight. So let's talk a little bit about the risks of surgery. This is a fairly comprehensive list of risks, and it'll look very similar to your consent if you have the surgery. So some of them are generic. We say that with any operation we do. Bleeding, infection, pain, scar, need for additional procedures. Okay? Now, risk from the anesthesia, like heart attack, stroke, blood clots of the legs or lungs, these are all with anything we do. Some specifics for these operations would be an ulcer, especially with the gastric bypass. All of them promote ulcer formation to a certain extent, so you can get an ulcer. You can get a stricture. I don't know if y'all can see way down at the bottom of the screen. A stricture is where we sew things back together. As it heals, it can become too tight, and we have to stretch it out. You can have excessive or inadequate weight loss. You could have injury to your intestines or leakage of the anastomosis. The anastomosis is where we sew things back together. That can leak. You can have damage to other abdominal organs like the spleen. And let's say that's damaged, it starts to bleed. We have to remove it. That would usually have to be as an open procedure or a big up and down incision. Or if for any reason we feel like it's safer to do it as an open procedure, we wouldn't hesitate to do that. We'll do whatever it takes to keep you safe. Now, we've never had to do that, but we wouldn't blink an eye. You could be converted to a different bariatric procedure, either during the surgery or later. You could have intractable nausea, vomiting, or pain. In other words, it never goes away. You could have pneumonia, large costs not covered by insurance if you're paying for it yourself, or death. So those are the risks. I'm going to kind of put those in perspective here in a little bit. Let's talk about the different types of surgery. Historically, we've said, well, these surgeries work by one of three mechanisms. Either they cause restriction, in other words, interfere with your ability to eat a bunch at once. They cause malabsorption, or interfere with your ability to absorb calories, or it's a combination of the two. The bypass historically has been the most common procedure performed in the United States. It's the gold standard bariatric procedure. It's one that has the longest history and the most data associated with it. So what we do with the bypass is we staple off about a 1 ounce pouch from the stomach. So if you put 2 of your thumbs together, that's about 1 ounce. We then sew your intestines up to that little 1 ounce pouch. So when you eat, you get full quickly, because this is small, and then the food travels all the way down here, bypassing the stomach. And then it mixes with the digestive enzymes made over here when these two limbs meet up. So you get restriction, and then you get malabsorption because you're not absorbing the calories as well. The complication rate is low. There's about a 1.25% major complication rate in the first 30 days after surgery. Of that, about 0.4% is leaks. About 0.14% is mortality, in other words, people who die from having the surgery. And DVT and PE are blood clots in the legs or lungs. That happens about 0.2% of the time. Now with the band, we kind of recreate that same small pouch by putting a little band around the top part of the stomach. And this pouch is smaller. It's about 15 cc's, or about half an ounce. When you eat, you get full quickly because this is small, and then you stay full because that band keeps that little pouch from emptying quickly. So it restricts how quickly that can empty. We can adjust that squeeze on that band with this little port that sits beneath the skin of your abdomen. You can see it, I'm sorry, you can feel it, but you can't see it. We can access that with a needle in the office and put fluid into it or take fluid out. It is the most follow-up intensive of all the procedures, and it's also the most easily reversible. The trade-off for that is the results in terms of weight loss are not as good as the bypass and the sleeve. The complication rate for bands is actually higher than the other two procedures, but they're by and large minor complications. So about 3% of the time it can slip, it can become obstructed 1 to 3% of the time, you can get a wound infection or abdominal pain or nausea and vomiting. About 1% of the time it can erode through the wall of the stomach and have to be removed. Reflux about 3% of the time, and then the death rate is about 0.05%, so about a third of the bypass. And then the sleeve gastrectomy is a newer procedure. This is just a restrictive procedure. The stomach starts as a sac, we remove this part and turn it into a tube. And that tube is about the size of a small banana. So it's about 3 to 4 ounces in size. The complication rate with this is also low, about 1%, 0.96, 30-day % complication rate. Leak rate is about 0.3%, and the mortality rate is about 0.08%. So just to kind of put this in perspective for you, a good way to think about this is you have the bypass here. It's quote-unquote the most risky, but it's also the most effective. Sleeve right here, a little less risky, a little less effective, and then the bands down here, way less risky, but way less effective. All right, but let's put this risk into perspective. Let's talk about another procedure that we do all the time, no one gets too excited about. So colon resection, in other words, removing part of your colon. We find that if we do elective colon resections, in other words, these aren't emergencies, they're done right early on Tuesday morning, they've gotten cardiac clearance and a bowel prep and everybody's fresh, the death rate is about 4.1%. So compare that to a high of about 0.14% with the bypass. The leak rate, or the chance of that anastomosis where we sew it back together leaking, is about 4%. Compare that to 0.4% with the bypass. In fact, when we do low rectal surgery, the leak rate can be up to 20%. All right, but that being said, the colon operation is still a pretty big operation. You spend 5 or 6 days in the hospital. It's a big procedure. So what about a day surgery that we do all the time? Has anyone had their gallbladder removed? Okay. So if you've had your gallbladder removed, your chance of dying from that procedure was somewhere between 0.2 to 0.4%. So compare that to the bypass at about 0.14%. It's safe to say that even our quote-unquote riskiest procedure is as safe or safer than having your gallbladder removed laparoscopically. All right. Now, remember how I said these procedures work. They either produce restriction or they produce malabsorption, and they do a combination of the two. Well, with the band, that's true. It's a restrictive procedure, that's how it works. It turns out with the sleeve and the bypass, that's probably not true at all. The way it really works, we're just now finding out over the past several years, is that it changes that set point. So you've got that thermostat set at a certain weight. These procedures dial in a new number for that. So whereas before, when you tried to lose weight, your body would take steps to bring you back up, now everything about your body is geared towards achieving that new lower number. And then when you achieve that number, your body will then defend that one. So they even did a little experiment on rats. And what they did is they put out a pile of carbohydrates, a pile of fat, and a pile of protein, and they let the rats eat whatever they wanted. And they did a pretty good job of mixing their diet. When they did tiny little gastric bypasses and tiny little gastric sleeves on these rats, they preferentially went towards the protein pile. And keep in mind, they didn't know to do that. They hadn't been to a rat seminar or had any education or anything like that. But their brain chemistry had changed such that they automatically needed the protein. So we know that their food preferences change, their food intake decreases, and their metabolism, or the energy expenditure, increases until those lines intersect and they achieve a new weight. So what kind of weight loss results can you expect with these procedures? Just to sum it up, with the band, you can probably expect somewhere around 40% excess body weight loss. So by that I mean what you weigh now minus what your ideal body weight is. That's your excess weight. So you can expect to lose somewhere around 40%. I find with the band that there's a pretty wide range though. Some people hardly lose any weight. I've had some people lose nothing with a band. Almost everybody loses about 20 pounds. I've had one person lose 150 pounds so far, but the range is pretty wide. On average, it's about 40%. With the sleeve or the bypass, you could lose somewhere between 50 to 70% of your excess weight. And we find that that's much more consistent. People in general will lose somewhere in that range with the sleeve or the bypass. All right. But like we said before, we really don't care how heavy we are, we care how healthy we are. So we would like to know, what is the effect of bariatric surgery on the other illnesses that go along with being overweight? They did this one study. They took about 6,000 people, and none of them had any medical problems at all when they started the program. They were just overweight. Half of them, they said, let's diet and exercise. And the other half, they said, let's do a bariatric surgery on you. And then they followed them for 5 years in the same way we would follow, say, a cancer patient or something like that. So over those 5 years, they noted how many people developed medical problems and then how many people died. Here's what they found. So the red group is people who did not have surgery. So they found that for issues like cancer, infectious disease problems, musculoskeletal issues like arthritis, endocrine issues like diabetes, and cardiovascular issues like stroke and heart attack, that the people who did not have surgery developed these problems at a much, much higher rate. Same thing for respiratory issues, mental health, skin, GU, blood. All of these were bigger problems in the non-surgical group. The only group where the surgery group fared worse was in digestive issues, which kind of stands to reason. We've radically altered your GI tract, so you're probably going to have more issues associated with that versus somebody who didn't have surgery. This is the most important slide in the entire talk. They found that if you had bariatric surgery, your chance of being alive at the end of 5 years was almost 90% greater compared to somebody who didn't. And this included the people who died from having the surgery. So a good way to think about this is, yes, there are certainly risks associated with having the surgery. Those are the ones we talked about. But it is far riskier to stay at your current weight. And that's the way we make any decision in medicine. I think about it like colon cancer. So yes, we know that there are risks associated with having part of your colon removed. We talked about those. But we know it's far riskier to continue to have colon cancer. Now, what about if you already have a medical problem? How good is bariatric surgery at curing that? This study took 22,000 patients from 136 different studies, and they combined the results and they averaged them. And they found that if you have diabetes, and if you have a gastric bypass, your chance of simply no longer having that disease is somewhere around 84%. So it just goes away. Now here's the interesting thing about that. That often happens within 24 hours of having surgery. So at that point, you haven't lost a pound, but all of a sudden you don't have diabetes. Well, why is that? Well, it speaks to the fact that these operations are really metabolic operations. It's not just about losing weight. There are a lot of weight loss independent benefits to it. We change your entire physiology when we do this, and so a lot of these diseases can go away very quickly, far ahead of any weight loss. Now, if you have sleep apnea, that goes away completely around 80% of the time. Hypertension somewhere around 70% of the time. And then all the lipids and cholesterol and all that, that gets better around 90% of the time. Now, if you have a gastric band, it's still very good. It's not quite as good as the others. So diabetes goes away around 50% of the time. Sleep apnea 95% of the time. Hypertension around 40% of the time. Now, what about if you have a sleeve? Well, the sleeve is an excellent operation. But one problem is that it's newer, so the amount of data that we have and the quality of the data is not quite as good. This slide's kind of hard to read, but basically what it says is that when you compare the gastric bypass and the sleeve gastrectomy, they're pretty much even except in two areas. Weight loss is not quite as good with the sleeve, and resolution of diabetes is not quite as good with the sleeve. So if we look here down here at diabetes, let's see, we've got, well, I'll see it on here. There we go, diabetes, there it is. So with the bypass, 92% went away completely with the bypass, 85% with the sleeve. So they're in there in the same ballpark, but the bypass definitely has a small edge in terms of diabetes. All right, so what to expect before and after surgery? Well, usually we start things off just with an initial consultation. So it's a regular doctor's visit. We talk about your preferences and your goals, what procedure you'd like to have. We do a history and physical, and then we arrange for any preoperative workup or consultations we may need. So that may include a sleep study if we think you have sleep apnea. It may include an upper scope if we think you have reflux or an ulcer or a hiatal hernia. And if you have any risk factors for heart disease, we would get a cardiac clearance. And then we put you into the program. So you have visits with dietary, psychology, you go to the seminar, and there's a lot of education involved in getting you ready for surgery. With the dietary evaluation, they'll talk with you about keeping a food journal. Another thing they found, I mentioned earlier, that just following up helps you to lose weight. It turns out that just writing down everything you eat will almost certainly make you lose some weight, even if you don't try to change your diet at all. So keeping a food journal is beneficial because it lets you know exactly what you're eating. And also some foods that you thought were good for you turn out to be pretty high calorie, and other foods that you thought were, low calorie turned out to be pretty bad for you. They're going to talk to you about eating slowly. So most people get into trouble with bariatric surgery not by eating too much, but by eating too quickly. Think of your new stomach as a funnel, right? You fill it up, it can only empty so quickly. So if you overfill it, it's going to overflow, and that's throwing up. What'll happen, here's what it'll feel like. You'll be eating, and you'll get a hard pain right here. And then if you eat one more bite, you'll throw up. And after that, then you understand what your body's trying to tell you. They're going to talk with you about no kind of grazing type behavior. What I mean by that is when you're eating a little bit all the time. So let's say you keep a little bag of chips with you, on your desk at work, or eating potato chips while you're watching the game or something like that. Grazing type behavior, you never quite eat enough to be full, but since you're doing it over a long period of time, you can actually get quite a few calories. And then we don't want you to eat while you're distracted, because that's when you end up eating too much or too fast. With liquids, we don't want you to have any liquid calories, because that just flows right through that operation, and you never feel full, but you get a lot of calories. But at the same time, we want you to drink 64 ounces of fluid a day so that you don't get dehydrated. Don't drink around mealtime either, because you'll wash all that food out of your stomach, and then you might feel hungry again. We want you to have a lot of protein. So that's probably the biggest change with a bariatric surgery diet, is we skew your diet way away from carbohydrates and way towards protein. So instead of storing those calories as fat and feeling hungry, you're building or preserving that muscle mass. And then, of course, you'll have to take vitamins pretty much for the rest of your life. Just basically a multivitamin, B12, calcium, and biotin. We've got little kits that you can get that kind of has everything you need in it. So the psychology evaluation is just designed to help you succeed. So it's not designed to exclude anybody. It's just so that you can be, psychologically prepared for the big changes that are going to come along with surgery. And then keep in mind that all these people that we have you see beforehand are also available for you after the surgery. So once you're kind of, in the family, then, you have, all these people are here to help you succeed after surgery. Once we do all that, you have your preoperative visit, we go over the results of all your consults, answer any questions you have, and then we schedule surgery. So a few specifics. Remember to bring your CPAP machine to your surgery. Unfortunately, that's the most common reason we have to cancel surgery, is because people don't have their CPAP machine. It's very important because, by definition, when you have sleep apnea, you stop breathing for a time at night. You add a little bit of sedation to that, a little bit of anesthesia, a little bit of swelling to your throat, from that tube we have to put down to breathe for you for surgery, what was before you stop breathing for a few minutes or a few seconds becomes you stop and you don't start again. The other thing about sleep apnea, why you should use it not only in the hospital but at home, is because when you have sleep apnea, your oxygen levels go down at night. And one thing your body needs to heal tissue is oxygen. So if at night, for basically a third of your day, you're not getting enough oxygen, that means that that operation we just did isn't getting what it needs to heal, and it'll leak. And so that's obviously a catastrophic, life-threatening complication. So by using your CPAP machine, that'll keep you safe, around and after surgery. The good news is that long term, almost certainly, that disease will be cured and you won't need it. Now, after surgery, the length of stay, of course, the band is an outpatient, the gastric sleeve is a 1-day stay, and the gastric bypass is a 2-day stay. So, 2 nights in the hospital. Afterwards, we're going to follow you up very closely. We'll see you 2 weeks after surgery, and then about 4 weeks after that, then every 3 months per year, every 6 months per year, and then every year forever. That's kind of just a sample template for what we use for follow-up. The reality is we follow up a lot of people even more frequently than that. There's plenty of people that for the first year I see every month or 2 months just to kind of make sure everything's staying on track. For your medications, we'll tell you exactly what to take before and after surgery. We'll tell you what can be crushed, what can be converted to a liquid, and what you can just take as is. At home, keep in mind, if you have high blood pressure, it may get better rapidly. So whereas before your blood pressure medicine was the right dose, now you're taking too much. So you might find that when you stand up, you get dizzy all of a sudden, or you start feeling weak. So check your blood pressure at home and make sure it's not going too low. And try to see your primary care doctor at least once in that first month after surgery so that they can help you adjust your medicine. Same thing with your diabetes medicine, because your blood sugar may start going low. Now, some people ask, well, my sugar's low, but you said I couldn't have any liquid calories. That's an exception. If you need to drink a little orange juice or something to get your blood sugar back up, feel free to do that. We don't want you to have any aspirin, ibuprofen, or any NSAID type medication. So NSAIDs would be what we call non-steroidal anti-inflammatory drugs. So other examples, Excedrin, Goodies, BC powder, Mobic, Celebrex, Aleve, any of those are NSAIDs. The reason is, we talked about all of these procedures to a certain extent promote ulcers, so do these medicines. So especially if you have the bypass and you take this, you're going to get an ulcer. And that can be a big, big deal. They can bleed or they can even perforate, and then you end up in the emergency room with peritonitis. So that's never happened to any of our patients, but I've certainly operated on plenty of other patients who have come into the ER, and that's the first time they had that there was any problems when they perforated their ulcer. So stay away from those. Now, you can take Tylenol. That's okay. And if you have to be on one of these medicines, let's say your doctor said, look, you have to be on an aspirin a day for your heart. Well, we can work around that. Just let us know, and we can give you other medicines to protect your stomach. Same thing with steroids. Steroids promote ulcers, and so we don't want you to take those. But even more importantly than that, steroids interfere with wound healing. So if you take steroids in those first 4 to 6 weeks after surgery, it can prevent your operation from healing, and it can leak. So a common scenario would be you sprain your ankle after surgery, or you get bronchitis after surgery, you go to your primary care doctor, and they want to give you steroids. If they want to do that, at least just call and check with us so that we can confer with them. Bruising. Everyone bruises. And you may not notice it till you get home, and you'll see it in your lower abdomen. And what that's from is those blood thinner shots that we give you. We protect you from blood clots 3 different ways. We put little squeezing devices on your legs. We give you blood thinners while you're in the hospital. And then we have you up and walking within 1 hour after your procedure. You're already doing laps in the hall. And all those 3 things together help keep you from getting a blood clot. But you will see when you get home, you may look in the mirror for the first time and you'll see bruises down there, and that's normal. If it's getting worse or it's excessive, let us know. In terms of pain, for the people who've had your gallbladder removed, most people say that it is less painful than that operation. But you will have a little bit of pain, especially with the sleeve. There's one larger incision that's about this big that's over on the left side. And if you twist the wrong way, it can get a very sharp pain there. And then once it hurts like that, it's kind of like you've sprained it. It's going to hurt then for a couple of weeks. So let us know about it, but probably all you're going to need to do is wear an abdominal binder or some kind of wrap to provide compression. And it's kind of like ACE wrap in your ankle. That'll help, help it to support it while it heals, and it'll be fine. Dehydration, that is far and away our most common problem we have after surgery. The way to avoid that is to keep a journal at home for the first 2 weeks. Drink every 15 minutes, and if you have, like an iPhone or an Android or something like that, just set the timer for 15 minutes. It'll go off, you drink, you hit reset, and you just do that throughout the day. So if you do, say, an ounce every 15 minutes in 10 hours, that's 40 ounces. If you do 2, that's 80 ounces. And what we'd like you to do is get at least 64 ounces a day. So keep that journal so at the end of every day you can look and see, this is how many ounces I had today. So warning signs are if your urine starts to get dark or if your urine starts to get strong smelling, then that means you're starting to get dehydrated. The symptoms other than that, you won't really feel dehydrated, you'll just start feeling bad. And you may start getting nausea, and of course then you can drink even less, or you may start getting abdominal pain, and then people have to come into the emergency room, and then at that point we don't really know what's wrong. So we might have to do a CAT scan or something like that, make sure there's nothing serious. But at the end of the day, 99% of the time, it's just dehydration. If you're having trouble keeping fluids down, popsicles are great for that. Get a sugar-free popsicle and melt it. Most of them are 3 ounces, and almost everyone seems to do great with those. So if you can do 2 of those an hour, that's 6 ounces an hour, and that'll keep you out of trouble. And then plateaus. So what I mean by that is that there will come a time when you stop losing weight altogether. It's usually the first 2 to 4 weeks after surgery, and you may go 1, 2, or even 3 weeks and not lose a pound. But don't worry, it happens to everybody, and just keep doing what you're supposed to be doing, and you'll find that all of a sudden you wake up and the next morning you're 5 pounds lighter. Just all of a sudden it starts again. And that's just kind of your body trying to get used to the new situation. It'll almost kind of fight you a little bit on the way down, but then you realize, oh, I guess we're going to keep losing weight, and then you'll just start again. And then no smoking. Of course, it's bad for you. But specifically with this operation, 1, again, it causes you to have ulcers. So we don't want that. And then 2, like with the CPAP, it decreases the oxygen supply to where we operate. So the first thing that happens when you smoke is all the blood supply to your intestines clamps down, and it's not getting blood anymore, it's not getting oxygen anymore, and so it's not going to heal. In fact, we require that you have quit smoking for at least 1 month prior to surgery. For exercise, we'd like you to do an hour of aerobic exercise every day. Unfortunately, sometimes some people lose weight with exercise, a lot of people don't. To the point where some people even train for it and run half marathons and will only lose a couple of pounds in the process of doing that. Now the difference is once you've had surgery, if you exercise, the weight will fall off of you. And one thing we notice is that the people who don't do that, those are the ones that don't really have the result that they're hoping for. And once they start, it's like magic. It just starts melting off. So there's a lot of positive reinforcement there. Whereas before, when you worked very hard in the gym and didn't get results, now you're going to see the results. So we want you to do at least an hour a day. We want you to do weight training. We want you to be lifting weights and doing all that kind of stuff, even for the women. What we've found is that even a modest amount of weights will reprogram your muscle cells on a cellular level such that they preferentially use fat as their fuel source. And that will help preserve your lean muscle mass as you lose weight. Because if you don't get enough protein and you don't do some weight training, up to 30% of your weight loss after surgery can be in muscle mass. And that's the exact opposite of what we want. We want to preserve all that muscle mass or even increase it while we're losing fat. So in order to do that, I'd recommend getting a personal trainer because they know things about fitness that you don't even know you don't know. I try to do everything that I ask you guys to do. And the reason I'm walking a little funny today is because I went 2 days ago and my trainer was not kind at all. And so now I'm pretty sore. But when I don't have my trainer, when he's out of town, I don't go. So if there's someone standing there at the gym waiting for you to show up, who frankly you're going to have to pay whether or not you go, you're much, much more likely to show up and do it. At least I am. So in summary then, bariatric surgery is just a tool. So it's just an aid. In order to succeed with this, it takes all the same hard work and dedication that you apply to any other effort to lose weight. The only difference is that this time it'll work. So lifelong changes are necessary, and the absolute key to success is follow-up.